Hi everyone, this is Group 8, and we are here to do the presentation for the topic of the cost utility analysis, and by G1, Qianzuo Li, Ruonan Ding, and Chaochu Shi. And today we have the 8 contexts to talk about. And first one is the model overview. Second one is the basic important clinical data. Third one is the decision tree model. Fourth, Magalov model diagram. Fifth, key model inputs. Six, key results. Seven, cost effectiveness applying. The final part is the group assignments of if the product reviewed is cost effective. And I'm gonna hand it first to Dr. Chu Qiaoshu.
Thank you. And I will provide some basic background of disease and drugs. And psoriasis is one of the most common inflammatory skin disease and affects about 2% of the US population. Plaque psoriasis is the most common form of psoriasis. It starts inside the body. The physical symptoms and discomfort, mental health impact, comorbidities, and effects on social relationships of psoriasis have negative effects on patients, leading to an overall decreased quality of life. Also, psoriasis has no cure but can only to choose the right treatment. So there's a large economic burden on payers and patients. So to choose cost-effective therapies that decrease disease severity is very important. The first agent is infliximab, which is the standard of care and the base case in our model. It's a immunosuppressive drug to treat moderate to severe plaque psoriasis. Its drug class is TNF blocking agent. And next, please. And the second biologic agent is TOS. It's an injectable medication for the treatment of autoimmune disease. Chemically, it's a form of humanized monoclonal antibody, and the substance acts by binding interleukin 17A and neutralizing it, reducing inflammation. The third agent is Stelara, an injectable immunosuppressive drug. It can treat plaque psoriasis. And next, please. And this is our model overview. We have 4 states qualities and healthy states defined as PASI 90 or higher. The utility is 0.85. Well-controlled disease defined as PASI 75 to 89. The utility is 0.77. Uncontrolled disease defined as PASI 74 or less. The utility is 0.63, and the utility for that is 0. And we also calculated the cost for each state and the transition probabilities for 3 drugs. And next, please. And this is our key clinical data input. We found those graphs from published articles and clinical trials, and we estimate our probabilities based on those research. For example, the chart on bottom left shows the results of TOS, and we use 92% minus 72% at week 12. And we got 20% patients are in well-controlled state, which is PASI 75 to 89. To define the likelihood of transitions, we looked at the differences between week 12 and year 2. We found that there are 2% more patients achieve PASI 75 and 9% more patients achieve PASI 90. And we estimate those additional patients transit from uncontrolled to well-controlled, and some portion of patients transit from uncontrolled to healthy. And based on the trend of 3 lines, we assume that there's a high probability that patient transit into uncontrolled state. And we used an average number as our assumptions of transition probabilities when combined. our research data together. And next we'll move to our decision tree model.
Thank you, Qiaoshu. And I'm going to talk about decision tree model and a starter as the treatments for plaque psoriasis. And we have the three medications you guys already know. They're infliximab, the Taltz, and the Stelara. And each one comes with the two options. First option is the response, the second is failure. And each option also comes with the two different probability, ADR and no ADR. So as you can see on the chart, it's very clear to see. And about next part is the Markov model diagram. And as you can see, we have the four Markov states: healthy, well-controlled, uncontrolled, and dead. So our tripping state is dead. We are landing people in uncontrolled state when they are coming into our model. Then we can start the new biologic. And as you can see, probability 22, 33, 11. Our probability of the transition staying at the Markov states, and P31, 21, and 32, the probability for staying at the current states. And probability 12, 13, and 23, the probability for transiting from the well-controlled state to another uncontrolled state. And the next two parts are going to G.
Thanks. So coming to key model inputs, our cost inputs includes drug WAC price from Redbook and adverse event costs from online sources and treatment costs about dosage suggested on Redbook and cost of productivities lost from online sources. And for our utility input, there are four status we are considering. They are health state, well-controlled disease, uncontrolled disease, and deaths. And our willingness to pay threshold is 50,000, 100,000, and 150,000. And our patients population size is 100,000, and their age is 25 years old. Our discount rate goes to 3%, which includes discounted costs and discounted collars. And the model cycle is going to be 20 years. And for our transition probabilities, we have them from online sources, calculations, and assumptions. Lastly, life expectancy is 2 million, which based on total population over 20 years in each state except that state. Next, please. The key results output is what we put here, and for the total cost of infliximab is 548,246.99, and the total cost of Taltz is 2,574,713.50, and the total cost of Stelara is 2,603,896.61, and followed by the discounted ICER. The differences between our primary drug versus Taltz is 17,940,287.75, and the differences between our main drug versus Stelara is 1,968,525.02. With this being said, Lydia will dive into our model plans to explain more in detail.
So this is the same plan for Taltz. In the graph, we can see that except the value we calculate also have three willingness to pay thresholds, which is the maximum the payers willing to pay. From left to the right is 50K, 100K, and 150K. As the willingness to pay goes up, the line gets steeper. And based on the final calculation, our cost per quantity for TOTS is about negative 18 million. And compared with standard of care, TOTS cost more and have negative quantities. So our value falls in the second quadrant and to the left of the three willingness to pay thresholds. Next slide, please. So this is the plan for Stellara. The value we calculate is about negative 2 million. Same as TOTS, also falls in the second quadrant and to the left of willingness to pay thresholds. Next slide. So to conclude, two biologic agents both cost more and less effective compared to standard of care, which means they both dominated. And based on the final result and cost effectiveness plan, values falls to the left of the willingness to pay threshold, so they're not cost effective. Next slide. So this is reference we found for the study. Next slide. That's all. Thank you for your time.
Thank you.